from PSV. I have just spoken to Dr. Romano. He has some issues with the laptop, but he's joining in shortly, and just in 2 minutes here. Thank you.
All right. Thank you so much for the update.
But in the meanwhile, if you want, can I present some slides about the company? It will take hardly 2 minutes since...
It's okay, please. You have some 2 minutes.
Yeah, thank you. Thank you so much. Yeah. Is the slides are visible?
Yes, please, they are.
I have 2 minutes, so let me finish it up in 2 minutes since Dr. Romano is going to join. So my name is Deepak. I'm representing BSV, which is a biosimilar company in Uganda. And on behalf of the company, I welcome each one of you. I know from your busy time, you are giving us a valuable time to discuss on a very novel, topic, which is fibroids and endometriosis, and how GnRH agonists play a significant role. I welcome on behalf of the company, and I just remove it. I think it got stuck somewhere. We have spent almost 50 years as of now as a biosimilar company, and we are the 6th largest in India. So this is just the journey, that how the journey started long back, in 1971, where the company have started, by selling just a RH vaccine for the RH negative women. Then in 81 to 2000, we have developed, a lot of products, which is specifically these are the immunoglobulins which have been manufactured against the Pseudomonas infections. In 2001 to 11, we have launched many of the products which is approved by the US FDA. Even we open our facilities in Germany also. We started our operations in Philippines. We launched a lot of products for the recombinant hormones for stimulating women for infertility cases. In 2012 and 2016, it has been taken over by the US company, and it is right now the 6th largest in India. And it has many products. We are into research, R&Ds, and even manufacturing a lot of products, which we have bring it for the very first time in the world market and even in the Ugandan market also. So these are the products like we have monoclonal anti-D immunoglobulin, we have tetanus immunoglobulins also. We also have amphotericin B, that is for invasive fungal infection. There are some other products which we have. We are the company known for the immunoglobulins. We have even equine rabies immunoglobulin, tetanus immunoglobulin, antithrombocyte globulin for aplastic anemia, amphotericin B in liposomal, which we have, carbopros injections and PPH injections, that is for PPH indication, sorry, Leuprolide, that is for endometriosis fibroids, and we have some of our drugs even for the infertility. In fact, we are the strong leaders right now in selling, recombinant FSH, LH, even HCG, and even Citralex also. So we have all these products in our kitty right now. We are manufacturing these products in a German plant, which is approved. All these products have been approved by the US FDA, even by the German GMP also. This is our own plant. Even another plant is in India where we are manufacturing most of the immunoglobulins and amphotericin. This is also approved by the European Union GMP and even by the Brazil. So these are the various products which we have it in our kitty. Some of our products they are available like Carbopros we have, that is for PPH. We have, it's available in NMS, even in JMS also. We have anti-D immunoglobulin, that is Roclone. Last time we had a meeting on this. We have, rabies immunoglobulin also available. Currently, we're marketing in more than 24 countries. And here we are saying that, how it works. Maybe I'm going to take up later on. Tetanus immunoglobulin, that is a human immunoglobulin. We are the only suppliers here. And in fact, these are all WHO approved drugs. As per the guidelines, we are selling it. And then we have the Ulina strong immunomodulators that specifically helps to control the cytokine storm. So HCG injections, we are promoting it for ovulation induction and even in threatened abortion also. So these are some of our products which we have in our kitty. These are very highly specialized niche kind of a products. Only 10 or 12 products are there, but they are very important in the segments when it has been considered. So thanks for your time. In fact, now I think Dr. Romano, are you there online?
Yeah, Dr. Romano is here and is ready to start off the presentation.
Okay, now let me close this one. Yeah, thank you.
All right, thank you, Professor Romano. You're very welcome. I already did an introduction. I introduced you. And we are all eagerly waiting to hear from you. Over to you. Thank you. Professor Romano, are you there? Desmond, is Prof on?
Yes, Prof is on.
Okay.
Let me call him. Let me call him. Just give me 1 minute.
Hello? Hello?
Yes, Prof, we can hear you.
Thank you very much. Good evening, everyone.
Good evening.
I'd sent my slides. I don't know if they can project them or do I need to project them from my computer?
You can project them from that side, Doctor.
All right, let me try if I can share.
Doc, can I share? I have your slides if you want
Okay,
me.
you can share. You can share.
Okay, thanks. Thanks.
Please share. Yeah.
Is it visible?
Yes, slideshow. Okay. Good evening, ladies and gentlemen and fellow colleagues. I am glad to be invited to make a presentation on a very important gynecological topic that affects a large number of women in the reproductive period, and that is fibroids. So today we shall talk about a little bit about the management of fibroids, and we'll look at it from the context of using a drug called Leuprolide Acetate. Next slide, please. That is the outline that we shall go through. Next slide. What are actually fibroids? They have different names, synonyms. You will hear some people calling them myomas, others calling them leiomyomas, others calling them fibromyomas, but they basically mean the same thing. They are benign tumors, monoclonal, that arise from the smooth muscle of the uterus, and they are mainly composed of disordered cells called myofibroblasts that are buried deep in the smooth muscle of the uterus with a large quantity of collagen tissue or extracellular matrix. When you look at the uterine muscle, the smooth muscle, you will notice that in the muscle that has been affected by fibroids, there's a high concentration of estrogen and progesterone receptors compared to the other surrounding myometrium. It is estimated that in the reproductive age group, about 30% of women will have fibroids, and by the age of about 50 years, at least every woman may notice that she may have a fibroid if you do a scan on them. Of particular note, globally, fibroids are more common in us of African descent, and in the reproductive age from around 15 to 49, 20 to 30% will present with fibroids that are symptomatic and are causing some discomfort to the woman who may have them. The picture above depicts large fibroid of a lady we worked on, and the fibroids were quite large, almost up to about a 20-week gestation pregnant uterus, but they had multiple of different classifications, subserosal, intramural, as well as submucosal. Next slide, please. What causes fibroid is not really known. What we do know that they come from a single cell, that is their monoclonal, and recent research shows there's a very big genetic predisposition. With studies showing that 40% of women who get fibroids, and these start quite early in this particular client, they may start as way back as 22, 25 years. There seems to be a translocation on chromosome 12 and 14, and the rearrangement of the shorter arm of chromosome 16, as well as rearrangement of the long arm on chromosome 10, deletion of chromosome 13, and also it's associated with people who may have trisomy 12. Of particular note, different growth factors have been implicated in the growth of fibroid, transforming growth factor beta, epidermal growth factor, insulin growth factor, and basic EFG growth factors implicated in the massive growth of fibroids. Also, fibroids are hormonal dependent. Estrogen seems to increase the production of extracellular matrix around the myofibroblast, while progesterone tends to increase the mitotic activity of the myofibroblasts. And this is very particular in the sense that you do not see fibroids growing in size after menopause, nor do you see them below the age of about 12 to 13. Associated risk factors are people who take one early menarche, nulliparous, and hence you see them more common in religious ladies. Age, older women tend to have fibroids more than younger women. African descent, if there's a family strong history of fibroids, and obesity. Obesity because of this connotation with increased oestrogenemia. Long-term use of contraceptives, injectable contraception, and pregnancies tend to be factors that lower the risk of fibroids. Next slide, please. FIGO, the Federation of International Gynecology and Obstetricians, changed the classification of fibroids. The common classification you'll find where we noted subserosal, intramural, and submucosal simplified classification, because most ladies who present with fibroids, you will find multiple types of fibroids that they are affecting them. And depending on the location of the fibroid, the symptoms may vary, such that we literally have about 8 classes, where we have submucosal fibroids we classify as 0, 1, and 2, where you can get a fibroid that is right in the uterus, which we call as class 0. Then we can get a fibroid like 1 if you look at the slide, where a proportion of it is in the mass of the uterus, but a large proportion of it is in the cavity and affecting the endometrial lining. And then 2, where you tend to have a 50% proportion. Then we have those that are mainly intramural, and then those that are subserosal. Many times when you operate these patients, you will find that about 2 to 5, they both have submucosal, subserosal. And the symptoms that they present will be dependent on which of these fibroids seem to be causing a large proportion of the problems. One of the biggest problems are those that mainly affect the endometrial lining, submucosa, because they are associated with significant abnormal uterine bleeding or heavy menstrual flow. Next slide, please. When you look at the pathology of fibroids, if you look at them grossly, you will find multiple discrete, round, spherical, pink, white swellings that have an encapsule around them. Microscopically, it's really non-stratiated striated muscle cells interlaced with bundles, and they have a wall-like appearance. Fibroids over time can undergo various changes. They can go hyaline, they can become very hard calcified, they can undergo necrosis, and in pregnancy, they can get congested with blood flow, and hence we get a red degeneration mainly during pregnancy, and at times they can undergo degenerations. As I said, fibroids are benign, they're innocent. However, a small proportion of them can become malignant, and this is reported in about 0.49 to 0.79%. Next slide, please. Next slide. Why are we concerned about fibroids? A large proportion of women will have fibroids, but they are asymptomatic. We tend to get concerned about them when they start causing symptoms. And these symptoms may usually manifest, as I had said, with prolonged menstrual periods that can last up to 5, literally 7 to 10 days. And this over time will be associated with low blood, anemia. You can get abnormal uterine bleeding, that even after your menstrual flow, you start getting irregular bleeding during the month. Patients may present with persistent abdominal discomfort in the lower abdomen. They may get obstructive symptoms. If the fibroids are large, they may get constipation, or they may get urinary symptoms, because those are two organs that are related to the uterus. And hence they may present with frequency, urinary retention, or even constipation. Fibroids that are subserous and pendiculated at times can undergo torsion with decrease in blood, and hence the person can present in an acute abdomen. Fibroids are associated with subinfertility, and the reason why they cause subinfertility, especially fibroids that affect the endometrial lining with poor implantation, but also with poor growth of the pregnancy, and at times also obstructive areas, especially around the fallopian tubes. But they're associated with subinfertility. Next slide, please. Effects in pregnancy. You can't get fibroids in pregnancy. When we get them, we monitor them very carefully, and they are associated with abortion, pressure symptoms, abdominal pain, especially due to the fact that in pregnancy there's an increased flow. In pregnancy, there's an increased flow of blood, and then there's an increased flow in congestion of the fibroids. By the time of delivery, we can get issues to do with a malpresentation, and at times they're associated with preterm labor, dystocia in labor. They can cause postpartum hemorrhage, poor subinvolution in the post-delivery period, the period, and then especially if you have submucosal fibroid or mucosal fibroid, at times they can get sepsis and you present with papillary sepsis. Next slide, please. Treatment of fibroid is individualized based a lot on the symptomatology of the mother. The size, the location of the fibroids, the age of the fibroids, and also the experience of the therapist, especially dependent on the type of treatment you're going to offer this particular patient. Medically, we can give non-steroidal anti-inflammatory drugs if the symptoms are quite mild. At times, if the fibroids are not so big, especially if they are less than 12 weeks, you can offer a levonorgestrel intrauterine device called Mirena, available in Uganda. If they are quite large and you're opting to offer surgery, we then recommend to give GnRH agonists like Leuprolide. Also available are other drugs like ulipristal, You can offer oral contraceptive, and within our settings now in some hospitals, not yet in some hospitals, you can offer uterine artery embolization, myolysis, and also magnetic resonance focused ultrasound that's not yet available in Uganda. Surgically, we can offer myomectomy or hysterectomy. Next slide, please. This is just an logarithm of how treatment can be offered. Next slide. Leuprolide acetate is a GnRH analog and is available in the market, both globally, regionally, and within Uganda. It comes mainly as 3.7 milligrams that can be given sub-Q IM for about 3 months prior to offering surgical treatment if you opt to give it to patients who are symptomatic with huge fibroids. Its main effects is that it produces a hypoestrogenic state and places the mother or the patient in a temporal menopausal state. Next slide. What are GnRH analogs like leuprolide? You need to understand that gonadotropin-releasing hormone is released from the brain, the hypothalamus. So here we are making analogs, and you can have a GnRH agonist or an antagonist, and this is really done by substituting the decapeptide, or similar to gonadotropin-releasing hormone analog at position 6 and 10. If you want agonistic activity, and if you modify 2 and 3, you'll get antagonistic activity. Next slide, please. This is just a depiction of where the alteration can occur. Next slide. When you're using an agonist like leuprolide, you could continue tapping. It mainly causes downregulation. Next. So it initially, continue. It initially causes an effect of stimulating LH and FSH, and later on, because of continuity of giving the agonist, causes downregulation. By downregulation, what really happens, the pituitary is suppressed and LH and FSH suppressed, and eventually you get hypoestrogenic state. While with an antagonist, it acts straight away on the receptor and suppresses the pituitary, so you go into a hypoestrogenic state straight away. Next slide. So agonists, repeated administration of an agonist in a continuous manner results in pituitary GnRH receptor downregulation. Gonadotropin secretion of FSH and LH is decreased, and eventually there's a decrease in steroidogenesis and gametogenesis, and you get a hypoestrogenic state. When an antagonist, occasionally used also in fibroids, there's an immediate rapid gonadotropin suppression by competitively blocking the receptor at the anterior pituitary. Next slide. When you're going to give leuprolide, as I said, you tend to give it for ladies who have very huge fibroids, usually over 12, 14 weeks, where your main focus is to try to see if you are going to preserve the patient's uterus for future productivity. And when you give leuprolide over a 3-month period, it can result in shrinkage of fibroids by 30 to 40%, in some of the literature, literally up to 50%. It decreases vascularity around the fibroids. There's a drop in uterine volume by 40 to 60%. It has the advantage that during the 3-month period, there will be an increase in the hemoglobin level of the patient, since there will be a cessation of menstruation. And also intraoperative blood loss significantly is lowered at the time when you're operating, and hence pure blood transfusion. So that's one of the major side effects and benefits of using leuprolide prior to surgery. Next slide. When you offer it, it's important that you can either do myomectomy that can be open, abdominally, vaginally, or hysteroscopically, depending on the size of the fibroid. It can also be done laparoscopically. This is a picture of some fibroids that were quite huge, literally up to about, equivalent to about 34 centimeters above the symphysis pubis. We offered the patient Leuprolide Acetate. They decreased it to about 24 weeks. And later on, we're able to do an open myomectomy. And these are some of the fibroids that we remove. Continue, please. If the patient is in the premenopausal state, she has finished her family over the age of about 46, 47. In that particular patient, the management and the discussion of that patient would be either offering an abdominal, vaginal, or laparoscopic assisted vaginal hysterectomy. Next slide. These are some of the fibroids that performed, and it shows the kind of surgery that was done, and the fact that during this particular period, there was a significant decrease in about 40 to 60% in uterine volume over a 3-month period. Next slide. What are the other options that you can offer apart from GnRH agonists like Leuprolide? You can offer an antagonist. You can offer a levonorgestrel intrauterine contraceptive device, especially if the fibroids are not so large and the person has opted not to have surgery. Or you can offer ulipristal acetate 5 milligrams daily. Next slide. Uterine artery embolization is available. It's mainly being done now in GnRH. It's mainly done by interventional radiologists. The catheter is passed retrograde through the right femoral artery to the bifurcation of the aorta, and you negotiate down to the opposite uterine artery, and polyvical alcohol particles are then injected through. Over time, it can cause a 67 to 65 reduction in uterine size, and it has been associated to improve in menorrhagia and also pressure symptoms. Next slide. This is just a depiction of how the catheter is passed through the uterine artery with guidance of good ultrasound, and then with the injection of the different particles. Next slide. Newer management, we have magnetic resonance focus guided ultrasound. It is thermal, and in it, there's direct ultrasound to tissues, to the fibroid without damaging of the tissues around. And it elicits coagulative necrosis by thermal ablation. At the moment, it's not available, but in many high-income countries, it's an alternative to patients who may not want surgery. Next slide. Thank you very much. I welcome questions. Ladies and gentlemen, thank you.
Thank you so much, Prof. Romano, for this elaborate presentation. Ladies and gentlemen, now our Q&A session is open. If you have any question for Dr. Romano, please, this is the time to ask. Doctor, you can look in the chat. There is a comment from someone, Vincent Bwere. He wishes to have a hint on the availability, efficacy, and cost of the different management options. Maybe as we wait to have questions from other members, Doctor, I would like to ask, does treatment with Leuprolide have any effect on a woman's ability to carry future pregnancies?
Leuprolide, we tend to offer Leuprolide in women who were trying to preserve the uterus so that they can conceive. As I said, you do find ladies in their between 25 and 35, some of them with extremely huge fibroids. of the size of about 20 to 30 centimeters above the symphysis pubis. And these are already causing symptoms, and you do know that these particular patients may have difficulty even when they get pregnant. As I told you, fibroids associated with complications in pregnancy. So for these particular patients, you are offering them a temporal cessation of hypoestrogenic state for at least 3 months. Then you offer them surgery. And after surgery, after a period of healing, literally after about 6 to 8 months, they're able to conceive. So offering Leuprolide does not prevent someone conceiving. What it does help is that it decreases the size of the fibroid by literally about 30 to 50%, decreases the volume of the fibroid, enables the surgeon to be able to dissect out those fibroids much better with a decrease in blood loss during the operation. Thank you. Regarding the cost of the different methods, it varies really from, I can only talk about, and I think Mr. Deepak will tell us more about Leuprolide. Leuprolide averagely goes from about 280, I think, to 300,000 shillings per month. So if you're offering it to a client, you are offering 3 doses. That's about 303. That's about 900,000 prior to offering surgery. And the surgery will be dependent on where the person is having the surgery, whether it's going to be an open myomectomy, whether it's going to be a hysteroscopic surgery, especially if the fibroids are submucosal or intracavitary, or whether it's going to be laparoscopic. So it varies. Laparoscopic myomectomy tends to be a bit more expensive. Open myomectomy tends to be a bit cheaper depending on the hospital that you're going to do it from. Thank you.
Yes, Joseph, your hand is up. Go ahead, unmute and ask.
Yes, thank you so much. Thank you, Professor, for the very good presentation. I have a concern in the pathogenesis of the fibroids and management, whereby we've seen that the estrogen and progesterone have a big role in the formation of the fibroids, but still that the risk of fibroids reduces with the use of contraceptives. Actually, we've seen that actually when we use certain contraceptives, the fibroids again reduces. I didn't understand that. Are they like both a positive way and negatively affect the development of the fibroids, the estrogen and progesterone there? That is my concern.
In the pathogenesis of fibroids, as I had said, there's a genetic component, but there's also a hormonal component. Fibroids do not grow after the age of 50 in your menopause. No, they grow below the age of 13. They are common in the reproductive age group of 14 to about 30, to about 49. And when you look at fibroids and you dissect them, they tend to have a high number of estrogen and progesterone receptors compared to the surrounding myometrium of the uterus. Estrogen and progesterone affects those growth factors and increase the proliferation of the extracellular matrix as well as the myoblasts. When you use contraception, you are actually indirectly, the way contraception works, most of the hormonal contraception, not every contraception, but hormonal contraception, you're decreasing the production of what? estrogen and progesterone, and you're thinning down the endometrial lining and you're preventing ovulation from occurring. In the same way, when you look at GnRH analogs, Leuprolide, the way it works, it causes a decrease in luteinizing hormone and follicular stimulating hormone from the pituitary, which in turn prevents estrogen and progesterone being produced by the ovary, which in turn creates a state in the woman's body of low estrogen concentration, and hence the fibroid shrinks with time. Even naturally, when you get a lady who has fibroids, when she reaches menopause, her fibroids over time will shrink in size because of the estrogen milieu or being decreased because she has reached a natural state of menopause. I hope I've answered and tried to explain how the pathophysiology of hormonal influence and contraception.
Yes, Prof. It is clear. Thanks.
Thank you, Prof. Vincent Wete, you can go ahead and ask. Meanwhile, Prof. Romano, there are some questions in the chat. You can look through, and I don't know if time will allow us to finish all of them, but they're there. Vincent, it's your time.
Thank you so much, moderator, and thank you so much, Professor. Now, I am wondering, in your experience, I know a number of people, before they come to the conventional medical practice, many of them start with herbs. So in your experience, what has been the effect of herbs in the management of fibroids? Are there herbs that are potent? Are the herbs harmful? Are the herbs harmless and they have no effect? Thank you.
By the way, all drugs come from plants. The only problem that we have, and we need to do more research, is to analyze a lot of our herbal medication to determine the content and the types of herbs or the type of chemical that's in this herb. At present, we do not have any significant traditional herbs that we can say significantly decrease fibroids or eliminate fibroids. Generally, the majority of us will always start with traditional complementary medicine when we're sick. And you'll find a lot of ladies seeking traditional complementary medicine when they are sick and when they have fibroids, 80 to 90%, before they come in for biomedical. And unfortunately, in the process, a lot of them suffer from being hoodwinked. I know there's a famous worker in Uganda who takes a lot of money from ladies, and I don't know how she does it. She tends to tell them that she's giving them medicine and they produce fibroids in the process, but they never bring out those products to say to you. So many people are doing. So at the moment, in reality, we need to do more research in herbal medication to pinpoint which chemicals are benefit. But at the moment, as of now, I cannot say that there are any herbal medications that we know of that significantly treat herbs. That treat fibroids, sorry. I could start with trying to answer some of the questions there are many. So I think I don't know where we should start, from down or up.
We can start from up.
I think some are tried. Let us see. Different options, availability, efficacy, and cost of the different management options. I think we discussed a little bit about that. Uterine artery embolization. Uterine embolization actually is effective, but there is some literature that seems to suggest that when you utilize it, the ability to conceive later on may be decreased. Although some studies have come out to refute that, but some of the studies that have come out actually show that if you do use uterine artery embolization for a person who's desiring to get pregnant, there is a decreased ability to conceive later on. But some of the studies have come to contradict that particular statement. The dosing of leuprolide, as I said, we usually give it as 3.75 milligrams sub-Q for 3 months, ideally, prior to offering surgery. And please remember, this is a temporal state. Some mothers may think that when they feel their size of fibroids decreasing and their clothing is quite, they're back to wearing almost all the best, that the fibroids are gone. It is temporal, and within about 6 months, the fibroid will grow. Aromatase inhibitors like letrozole, in the management of fibroids, I will not comment so much about that. I do not have a lot of information about that yet. How long should a woman undergoing via abdominal take to conceive? Usually you give her a break of at least 8 months before she tries to conceive, because you want healing of the scar to occur, literally even up to 1 year. It's the same way when we have cesarean sections, we tend to give people time for the uterine scar to heal. And please remember, depending on the type of fibroid, if it is one where you had had to have excision through the whole myometrium to the endometrium, then those particular times, please give them time to heal. If it was a pendiculated fibroid where you're just tying the pedicle, those are the ones that can actually even conceive as soon as possible. The success rates of leuprolide, I think we said it in the study, it goes up to about, there's a decrease in size literally to about 30 to about 50% decrease in volume. Pregnancy is the same as having multiple pregnancies, and the fact that in the puerperium you're in a state of hypoestrogenemia tends to decrease the risk of you eventually getting fibroids. All right, it's little to do with the hormonal milieu that you have when you have multiple pregnancies, and all within the post-delivery period, sort of protective. Yes, it is true that when you use analogs and when you're doing surgery, depending on the fibroid, the types of fibroids, at times the plane of dissections of the fibroid is what? Is decreased. As I said, fibroids undergo changes. Some of them calcify and they get a very good capsule. Some of them undergo hyaline changes. Some of them undergo fatty changes. Some of them undergo regeneration. At times when you give a GnRH analog, some of them will undergo regeneration. And when you do the operation, those plane of dissection tends to be what? Tends to be a bit difficult. But overall, when you're looking at in terms of the benefits of a decrease in size, a decrease in volume of bleeding, I would consider you offering them and still going in and doing the operation. Yes, it is true, the surgical planes at times tend to decrease. And when you're giving these agonists, you need to tell the people that temporarily within the first month of the first injection, they may get a flare up in terms of feeling as if the size of the fibroids will eventually is seeming to grow. But eventually on the second and the third month, the fibroids tend to significantly decrease by the percentage of decrease that we had said, right? Modality of management related to a pregnant woman with either trimester or gestation. Fibroids, if they cause symptoms during pregnancy, especially with pain, most of the time we manage them expectantly and conservatively. And over time, usually when they reach the second trimester, that pain sort of subsides. up to the time when you will determine the type of delivery depending on the size, location, and the presentation of the baby. Not all fibroids, not all women with fibroids necessitate having a cesarean section. Some with fibroids will deliver well, even with the fibroids, provided it's not causing any dystocia or obstructing or causing a malpresentation. Can leuprolide be taken for a lifetime? Wow, that's a hard question. But at times, with some patients, we can give leuprolide, and we call what we call leuprolide advert. And these are usually in scenarios of patients who have other gynecological conditions like endometriosis, where you give long periods of time with leuprolide and add on a progestogen like norestestrone to decrease some of the long-term side effects of hyperoestrogenemia. Yes, you can give it, but rarely we give it for a long period of time, or over 6 months, in scenarios of fibroids. Usually 3 months, then you offer surgery. But for other gynecological conditions, especially severe endometriosis, at times offering long-term use of leuprolide and advert is an added advantage, all right? Is prolonged nulliparity a risk factor for developing fibroids? Yes, as we stated. Leuprolide can subside by the 5th month. As I said, you give it for 3 months, and total effects by 6 weeks to 8 weeks from the last injection, the effect sort of subsides away. Patients with recurrent fibroids after myomectomy, as we had said, provide the person is in the reproductive period. When you do a myomectomy, you make an effort that patient, over the period of 2 to 3 years, he with a partner may be able to get the family size that he wants. When a patient now gets recurrent fibroids coming in, then the discussion of what to do next will be dependent on the person's symptoms, the size. So it's not a clear-cut statement that you will do another myomectomy. You may need to discuss it and reassess how big the fibroids are. At times, the risk of doing hysterectomy tends to increase, especially when they tend to grow again. Is leuprolide capable of shrinking the fibroid without surgery? It will shrink the fibroid, but when you take it off, it will grow again. So you need to tell that the patient that it's not totally taking away the fibroids forever. It just shrinks it for a period of time and it goes away, right? Good. I think I've tried to answer most of the questions. I don't know if there are any others. What would be the essence of surgery following the use of leuprolide in fibroids? Yes, you see, as I had said, you don't offer leuprolide to all fibroids. You offer leuprolide to patients who have extremely huge fibroids and who have significant symptoms. Usually, we tend to offer them with patients who have fibroids of greater than 20 to 24 centimeters and above. There are times in Africa, in our settings there, you find patients with fibroids that are literally 30 centimeters above the symphysis pubis, and yet they want to conceive, and you're trying as much as possible to preserve that particular uterus. So you shouldn't just offer it as a way of expectant management. You should offer it with an endpoint of offering surgery at the end of the day. There's a thing here, about a patient presenting with large fibroids. Yes, she could come, the assessor, and then we see whether she will benefit from it, all right? Yeah. I think I've answered most of the questions. I would welcome any other comments. There's Sharon who wants a question, please, Sharon.
Thank you so much, Prof. My question is, you find women come with complications during pregnancy, and then they end up having an abortion, and they really have big fibroids, like 20-week size and something like that. After maybe expiring, how long would you take to start using Leuprolide so that you can optimize them for surgery? Thank you so much.
Who has had an abortion and you highly anticipate it may be related to the fibroid, you need to assess that fibroid, do a good transvaginal scan as well as an abdominal scan, and look at the size and location. Not all fibroids actually cause. You need to first determine were these fibroids associated with the abortion, or will this abortion lead to some things. But fibroids, after doing a transvaginal scan, that are usually submucosal, all right? The ones that are usually associated with abortions, then those particular ones, after she has recovered, possibly after about 8 weeks, you can then offer the chance of undergoing treatment with GnRH analogs before you offer surgery and before you contemplate offering up pregnancy within the next 1 year.
Thank you so much, Prof.
Thank you so much, Professor Romano, first for the elaborate presentation in management of fibroids using Leuprolide Acetate. Secondly, for addressing all the concerns that have been raised. Yeah, and before I invite Professor Peter to appreciate you, I would like to give just 1 minute to any person with a burning comment on the presentation, just one person, and then we'll kick it off from there.
Or somebody asked about polyps. No, Leuprolide, we don't use Leuprolide for polyps, uterine polyps. Usually those ones need excision, usually under laparoscopy, hysteroscopy, or we can actually do polypectomy. So we do not use Leuprolide to shrink polyps. Thank you.
Thank you, Prof. Anyone with a comment before we come to the end? Okay. If there isn't any comment, I would like to remind us about subscription for Busoga Health Forum. For institutions, subscription is 500,000 annually, and for individuals, it's 100,000 shillings annually. And then to become a lifetime member, you pay 1 million shillings. Yes, at this moment, I would like to invite Professor Peter Waiswa to deliver a vote of thanks to our speaker tonight. Thank you. Over to you, Prof.
Hello. Sorry, I was raising my hand. I thought I didn't notice. Before,
Okay, Maria.
Professor,
1 minute. Thank you.
yeah, I have a comment. My name is Mariam Nakamia. I work with Byaruhanga on vaccine. I'd like to thank Professor Romano for a wonderful presentation. I believe most of us we leave tonight with all our answers, with all our questions answered. As I work with Byaruhanga and vaccines, I would like to inform you that Leuprolide Acetate will be found at all Abacus branches. We have a number of branches around Kampala, and we have a branch in Jinja. So anyone in need of Leuprolide, you can pass by our branch and get the drug. For any more information, I'll share my contact here so that you can call or text me in case of anything or any other inquiry. And easily get you to Dr. Romano so that he can answer the questions that might not be answered here tonight. Thank you very much for this opportunity. We appreciate the chance that we put in today and looking forward to more opportunities. Thank you.
All right, thank you, Madam Mariam Nakamia. Prof. Peter went off shortly. I would like to invite Dr. Mukembo to appreciate our speaker. Dr. Mukembo, over to you.
Yes, thank you very much. I don't know, am I audible?
Yes, you are,
very
Doctor.
audible.
Yeah, I always have network challenges at home, but I want to, with great humility, send our sincere appreciation to Professor Romano for such a very wonderful presentation, and want to thank you very much for sparing your time to sit aside and talk to us as audience of Busoga Health Forum. We thank you for the package you prepared for us, despite your commitments. We do not take it for granted that you spare time and take Busoga Health Forum as a priority forum. We want to thank you very much and request you that once again, when you find it necessary, professors usually are too busy people. When you find it possible within your timetable, kindly let us know, and we have more engagement at Busoga Health Forum. Your topic was very enriching, and I'm sure people would have loved to ask even more questions. It is rare that we have such interactions with professors of your caliber. Kindly accept our sincere appreciation as Busoga Health Forum with this seemingly simple certificate, but it is from out of love as Secretariat of Busoga Health Forum that we appreciate you for sparing your time to present to our audience. Kindly we request you to receive this certificate of appreciation. And to you, Miss Daphne Nayebare, we thank you very much. We know you are a very dedicated health worker, and we thank you for the transformative efforts that you offer to the community of Busoga in your service. The patients give us feedback, but especially Busoga Health Forum would like to thank you for moderating this session, and kindly please receive this small token of appreciation as a way of saying thank you for the service you've offered to Busoga Health Forum. Members, join me to thank Professor Romano and Ms. Daphne Nayebare for giving us the presentation tonight. And on behalf of the leadership at Busoga Health Forum Secretariat and Busoga Health Forum Board, we would like to thank you, our presenters, and thank you, those of you that always make it a point to join us every Friday in our CME sessions. We will not take your time for granted, but our sincere hope is that you always learn a thing or two, or you improve or change something in the way you care for patients. What we present here is not only for the benefit of Busoga region, but it benefits Uganda at large, East Africa, Africa, and we have attendees from across other continents. So we thank you and we pray that you improve your client or patient care skills as you come to learn every Friday. We humbly want to request you, as echoed by the moderator, please join us fully to be part of Busoga Health Forum by only making a subscription of 100,000 to be a full member. And if you would like to be a life member, you can only make a contribution of at least 1 million and you'll be our life member. And then it may be your organization or institution that would like to be part of us at only a fee of 500,000 per year. And we will always invite you to partner in all our activities that we organize in the communities. Those of us who are part of us, we thank you for keeping alive with Busoga Health Forum. Thank you, everybody. And from me and Busoga Health Forum Secretariat leadership, we want to wish you a wonderful weekend. Thank you very much.
Thank you very much.